Well, thank you so much. I appreciate the opportunity to be here, and I look forward to sharing my expertise with you. So when they asked me to do this talk, they said they would like to know really the patient's voice, the patient's perspective. I just published a study in BMC Urology doing exactly that, the patient's perspective. So I'd like to start with a quote from a patient from my study. If you have a lack of sensation, you don't have nocturnal erections. You don't wake up with an erection, and I miss that. I miss it a lot. I miss the sensations and how I used to feel down there, how my body used to feel. I don't feel whole, and I think about it every single day. It's the first thing I think about when I wake up in the morning, and it's the last thing I think about at night. I miss it. So what is it like for these patients, and what are they struggling with? That was a prostate cancer patient, and if you would like to learn more about their words and their powerful stories, you can look up my publication in BMC Urology, and I think I have it in here. So I've got lots of stuff in the slides for you, but I'm mostly going to share stories. I'm going to share my stories about my patients, and I want you to hear their voice and what it's like to have sexual dysfunction after prostate cancer. So my PhD is in sexual health research, and I'm board certified in urology as an advanced practice clinical nurse specialist, so I have prescriptive privileges for those reasons. And then I'm also certified as a sexuality counselor. All right, so I bet if we went around the room to see what you thought about what is sex. Raise your hand. Anybody tell me, what do you think sex is? Throw out, or you can just yell out. What do you think sex is? What is it? Nothing. You all don't think about sex. It's after lunch and you don't care. Okay? Well, some of it you're born with. In other words, it's intrinsic. It's definitely multidimensional. And what people think of as starting sex or beginning sex or when you launch into sex in China or in Asia may be very different from here. And in fact, when Ed Lauman, who's at University of Chicago, studied across the world, he found that honestly, it's very different across cultures. So we know it's culturally derived. But I bet if we asked everybody, we'd probably find as many opinions as we have in the room as what we think. What is sex? What's sexuality? And today, more than ever, people come in and we can't assume anything. We have to ask them what they want to be called, what their pronouns are, lots of different things, because it can be fluid. It can change. Even someone who came into you in 1 week talking to you and asking you to call them a certain name or pronoun, sometimes some of my patients, it's a different pronoun and a different name, bless you, the next week. So it can vary greatly. But for our purposes, let's think about the acts of sex. Even though we have some presidents who call it certain things and others who call it other things, we say anything to do with genital stimulation, anything that involves pleasure and genital stimulation, we count that as sex. So that's what we're going to think of when we talk about sex the rest of the time that I'm talking this afternoon. Intimacy. It's a distinct concept that's different from sexuality. But it's one of the things that drives so many patients into my appointment, and it's reason why I keep Kleenex in my office all the time, because it's very distressing to people to have a lack of intimacy. It's heartbreaking for couples to live together, living parallel lives, and the love and the connection and the interconnection is gone, the intimacy. So Hatfield said, and I'm working on this, we're going to come up with an even better definition, but she said it's the process by which two people attempt to move towards complete communication on all levels. Communication on all levels, physical, emotional, spiritual. Connectedness. Brene Brown says connectedness is that energy that exists between two people when they feel heard, seen, and valued by the other person. Connectedness. We are hardwired by connectedness. If you want to know more about that, look at the work of Andrew Goldman. He actually looked at and put together and synthesized all of the research on connectedness and how we're hardwired and we have to have connectedness with other human beings. It's not optional. Same thing with love and belonging. Remember Maslow's hierarchy of needs and all those things, love and belonging? We are hardwired for love and belonging. So it's very distressing to people when they don't feel connectedness, love, and intimacy with their partner. So when patients come in, they're looking for they come in and they want to understand and they want to enhance intimacy, connectedness, communication on all levels with their partner. It may or may not include sex. Sometimes it does, sometimes it doesn't. You can have connectedness with people that you're not sexually involved with. You have intimate relationships, possibly with a parent, with a sibling, with a friend, but this is a little bit different. This intimate relationship also typically will involve sex. So intimacy in a loving relationship is what you'll hear me talk about. Okay, so, oops, flip too far forward. Let's try it again. All right, so let's go back just a smidge. All right, so there we go. Male sexual dysfunction. What is it? What goes wrong? The most common problem in men and women in the United States age 1859, according to the research, is lack of desire. A lot of people are surprised by that, but a lack of desire. We're so busy. We have so many things in our lives. We're multitasking, and so lack of desire is the #1 complaint, low libido, or if testosterone is low as well, that would be called hypogonadism in men. Hypogonadism is a syndrome that means that you have a low T in your blood level, but you also have symptoms. You don't have hypogonadism if you have a low T. You simply have low T. But if you have symptoms and a low T, that's hypogonadism. Erectile dysfunction is the inability to get or keep an erection sufficient for sex. So that can be really challenging, and this is the #1 complaint of men as they get older. In their 40s, 50s, 60s, you got about a 1 in 5 lifetime risk of erectile dysfunction, but by the time you're 70, about 70% of men will have erectile dysfunction. Not so much because of the aging process, but because of diseases that come with aging, like cancer, but also diabetes, heart disease, all the different things that can affect blood flow and nervous conduction, which are vital to sexual function. Orgasm disorders. It goes too quickly, it goes too slowly. We see some of each of those. The #1 complaint in young men in their 20s is premature ejaculation, because women in general take 4 times longer to climax than men. That's a generalization, but in general it's very true. Masters and Johnson showed that research, and it's been shown since then. Some people can't climax because of medicines like SSRIs or antidepressants that shift serotonin and dopamine in their brain in such a way that they're unable to climax, or they've had nerve damage. They might have taken chemotherapy, or they had radiation therapy. Lots of things can affect your ability to climax, and that's part of the pudendal nerve system that is separate from the cavernosal nerve system, which is what gives erections. So once the nerves come off the tailbone or the spine, they split into the cavernosal nerves and the pudendal nerves. So men who have erectile dysfunction can typically climax fine if the only thing that was damaged was the cavernosal nerves from prostatectomy or radiation. But they can't get erections, but they can climax without a problem because they're wired separately. That's important to remember because those men can still enjoy that sensation of climax. And even with the prostate gone in the absence of ejaculate, most men really enjoy that climax feeling. And they describe it as either diminished or different, the same. About 7% have more intense climax after they have prostatectomy. We'll talk more about it in a minute. So I just wanted this slide to be put up there for you to know that many of your patients, up to 90% of patients, and these are just some of the studies over that last decade, and you can see that a lot of them were done around the turn of the century when they were looking a little more at sex and intimacy, but they found lots of men and women struggle with sexual dysfunction after cancer treatment. And then I talk about some more specifics of how that happens, from chemo, from radiation, from surgery, especially if it's in the pelvic area. Couple statistics to let you see that yes, most of the men, in fact about 8 out of 10 men 2 years after prostatectomy will still struggle with erections. Even though sometimes surgeons say, well, they have erections. How do you define an erection? I asked a surgeon that once, how do you define it? And he said, stuffable. Stuffable? So how do you stuff an erection? I mean, really, you count that as an erection? We don't count that as an erection. Is it hard enough to, are you hard enough to get and keep an erection that you can get through sex the way you want to? This is a huge cross-sectional study, and they found 8 out of 10 at 2 years and 72% at 5 years were still struggling with erectile dysfunction. This was the study I was talking about earlier, and you'll see the citation on the next page. But it was a mixed method study where we asked men and their partners about their experience with sexual dysfunction after prostate cancer treatment. Tell us in your own words what that's like. And that was one of the quotes I gave you, and I'll tell you another one in just a minute. We also had them fill out validated questionnaires to see do they show too that they are struggling with erectile dysfunction? And of course, we find that very often with these men after prostate cancer surgery. We recruited them all across the country from my practice here in Chicago, but also from my speaking at different groups across the country, prostate cancer groups on the East Coast, the West Coast. We recruited all over. And so what we found is patients really need and want accurate information, that intimacy is monumentally important to these couples. Intimacy sometimes becomes non-penetrative, and they become experts at outer course or non-intercourse types of sex. But intimacy was vitally important, and they really need support from both their partners and other people in the community, including support groups. I'm going to give you another quote from that study. This patient described it this way: "Because this absolutely sucks. It's been very, very, very difficult for my wife and I. I feel a great amount of guilt for her even being with me, a great amount of guilt. But why did I even propose to her and subject her to this, what I consider to be an unfulfilling marriage? How else has it changed? I don't know. I feel like in every single conceivable way, the way that I look at the rest of my life, the way that I look at everything." So these patients are, some of them, not all of them, are really struggling with these types of issues. What about the colorectal patients? You can see there too, I'm just showing you that 68% of the rectal patients and 47% of the colon patients, most of the patients with rectal surgery or rectal treatment had erectile dysfunction or sexual dysfunction. So you can just see from some of these that the majority of patients will be suffering with sexual issues. And that's why we're here, and it's so great that you believe this is important and it's part of your conference. And I'm so happy that you do, and I hope that you find all of this helpful. Lots of things we can do, but the truth is, when people walk in my office, what they want is, give me back what I had. If I could do that, I would have a line around the world going to my clinic, right? Give me back, I think it happens, it's that simple. The closest we can come to that are pills. Pills don't work unless you think it, or you're being stimulated on the penis. They don't work. They work like a double negative. They block something called PDE5, phosphodiesterase type 5, which is an enzyme that inhibits the chemicals in your penis that make you hard. So it's like a double negative. If we inhibit the inhibitor, now we have more chemicals in the penis. So what? Unless you're excited, they're just going to sit there and do nothing. When you get excited, they're activated and you have potential for better erections. They work in about 60 to 70% of men with true physiologic erectile dysfunction, but the failure rates can be as high as 88% after prostatectomy, because now the communication between brain and penis are no longer clear, right? Because they peeled the nerves off, they dissected them off the back of the prostate, and even though they leave them, they were never meant to be touched, so they become inflamed. And you saw most of the men, they don't recover, because communication back and forth, the chemicals are there and they're ready, but the penis has no clue that it's supposed to do anything. Men lose their nighttime erections. If you've had sons or you're men in this audience, you know the penis works out while it sleeps. God, why can't the rest of our body work out like that, right? I mean, seriously, while we sleep, just work out, get it done. Well, the penis does exactly that. It literally works out while a man sleeps to keep itself in shape so that he can continue to have good, hard erections and for cardiovascular and endothelial health within the penis. So, very important. So again, the pills don't always work after cancer treatment. Sometimes we have to use a local therapy that works right on the penis, like the vacuum pump, or, God bless you, or the injections, or the pellet, or something that works right on the penis. If they get hard to start with, sometimes we can use something very simple that they can get on and off. You don't want any of those hard rings that get stuck, because then you're in the ER with the snips coming at your penis, and it's not a fun visit. So just trust me on that. So you slip this over the hard penis, and you pull on the end without the ball. The ball catches in the ring, and it holds the penis hard while the patient or the person is getting through sex. When they're done, they loosen it. They can't wear it more than 30 minutes max because it is trapping blood, but it's like a tourniquet that just helps hold the penis, the blood in the penis, while they're having relations. So that can be very important. But still, my job, you could go to a urologist, you can go to whoever and have it prescribed. But what we do in our office, it's about, okay, great. So now you have a prescription, or you can get this over the counter too. You go get this. Pull that out with a new lover. How's that going to go for you, right? Hi, honey. What's that? What's that about, right? So, or even your regular partner. How do I incorporate this into my love play? What do I do with this? This one man and woman came to see me, and we talked a lot about non-penetrative sex. And the woman said, I don't understand all that. In fact, I hear people talk about the clitoris all the time, but what is that exactly? So, of course, I pulled up diagrams, and I pulled out models, and I showed her, this is what the clitoris is, this is your vulva, this kind of thing. And she was like, wow. She's like, I didn't eat. She's like, honestly, I've never even looked down there, so I don't know exactly what's down there. And I'm like, would you like to look down there? She's like, I'm a little scared. I said, don't be. But anyway, so we got them both. We did some sexual education, and they learned about it. So now he was paying more attention to that, and so they were working on that. Because I said, whether you get an erection or not, regardless of that, I want you to work on sex and intimacy. I want you to really work on it and enjoy it. Because the minute you start worrying about it, now we throw anxiety. Anxiety equals adrenaline. Adrenaline equals fight or flight. Do you think if you're running from a predator, your penis is going to remain in your blood's going to remain in your penis? Guess what, folks? It's not. It's going to go to your brain. It's going to go to your muscles. It's going to go to your heart. It is not going to stay in the penis. So as soon as you get anxious, it is really hard to kill a 17 or 18-year-old erection, but I have men walk in my office all the time that are killing it. And they're killing it through anxiety and adrenaline, a physiologic response to a psychological stress. So bottom line is we've got to get them to let go of that and think, whatever happens, it's good. Women can climax with or without an erection. Masters and Johnson showed it decades ago, and it's been shown over and over by Kinsey and every other researcher since. Men can climax with or without a hard erection. So just enjoy it. Why are you having sex? It's about connectedness, pleasure, orgasms, and you can do any of those without a hard penis. So, but that's a really hard mindset for a man. And I'm a man too, I understand that. When your whole life, it's gone up and down, it's part of who you are. So this is a difficult thing. The women have this aha moment. I've seen them sit in my office and fight. It's fine. You know, I don't care. The intercourse, it kind of hurts and it's not uncomfortable because I have dryness. And so it's okay with me. She's just saying that to be that nice. I'm not that nice. I'm telling you the truth. I mean, this is the discussions that occur, but it's hard for us to accept. Maybe she isn't telling me the truth, because already I've had a huge strike on my ego and who I am because of the sexual dysfunction. So we've got to look at all this, and we have to pull it apart. So we worked on that. Then I taught him how to use the vacuum pump, but they were doing all this other stuff. And he came back, and he's like, we had success. He learned how to use the vacuum pump. He's like, it's going great. The next visit, he comes back, and he sets it on the desk, and he goes, here, you can have that. You can give it to another patient. I'm like, we don't really recycle these. It is a lovely gesture, but I don't think we're going to probably do that, but thank you. What is going on? And he says, well, we talked about it, and we're having so much fun without the erections. She said she's having the best climaxes of her life. Post-prostatectomy, he was a lucky guy who was having the best climaxes of his life. And he said, why do we need it now? I said, if you're okay with it, what do you need from me? He's like, is it okay? I'm like, it doesn't matter what I think. Are you okay and is she okay? And they both agreed it was fine. So they stopped using the vacuum pump. Even though it worked perfectly for them, they didn't have troublesome side effects, but they were just having such a good time without it, they stopped. But, so it's got good and bad. It's got positives and negatives. So we try to break people out of this way of thinking a little bit. When Brene Brown did her research, which is what this slide is based on, when she did her research and she said, what is vulnerability? What makes you feel vulnerable? Countless participants said asking for or being asked about sex and intimacy. So this is a place where it's hard to step in the arena, to say, I love you, I want to be with you, I'm not sure if my penis is going to function or not, but I want us to be together and I want to work on this together. Those are difficult conversations to have. And vulnerability is scary. So then we say, I'm not going to have sex, I'm going to avoid it, I'm not going to do anything. That, though, doesn't work that well either, because now we feel disconnected. I don't hold his hand anymore, Dr. Albaugh. I don't hold his hand because if I hold his hand, maybe he thinks I want sex. And I don't want to put that pressure on him. I don't start something I can't finish. Well, first off, you can finish it because you can have connectedness, pleasure, and orgasms whether you have that hard penis or not. So you can finish it, but How do we get them out of that place where they don't even touch each other or hold hands anymore? That's what my job is, to try and help them see their way through that. And that's what happens in my office all the time. So what are our goals? What are their goals is all that really matters. It doesn't matter what the doctor who sent you to me or the psychologist who sent you to me or whoever sent you to me, the nurse practitioner, the nurse. What do you want? What is your goal with intimacy? Do you want, all of us want, to feel heard, seen, connected, valued by that other person? How can we give you more of that? You are a cancer survivor. More than ever in your life, you need connection and intimacy with your partner. So these are the things that we work on with them. What are their goals? How do they want to get there? And sometimes it's just, I want to feel connected. I want to feel closeness. And those are very achievable goals. So we start communicating around it. We start talking about it. We start looking at all of it and see how can we get them towards their goals and only their goals. How do we reclaim desire? Sometimes it's like, I don't even care about sex anymore after the chemo and all the different things, but my partner does. So we have to work on a lot of different pieces. Desire is a complex thing, and that's why I gave you this side to look over and to think about, because it has to do with motivation. When you're on androgen deprivation therapy, sometimes the motivation's gone because the testosterone is completely depleted purposefully. So it can be complicated. The essence of sexuality is giving and receiving pleasure. Can we increase connectedness and pleasure? And these are the things that we try to work on. Sometimes, like today, I saw a couple earlier today and we talked about it, and she said, it doesn't feel good, it hurts, the dryness and the pain with penetration. And I said, well, why would you want to have sex when every time you do it, it hurts? Do you think, who would, well, some people want to do that. Some people like pain with sex. But most people, no, right? It made perfect sense she didn't want to have sex. She had testosterone replacement, actually, which was off-label, but the bottom line was she still didn't have a motivation because it hurt. Now we had to find a way to make it pleasurable for them to be intimate and use their senses to enjoy each other. So we do things like sensate focus, plan love play, working on things, taking things like intercourse off the table that hurt so we can do things that feel good and are enjoyable. I put some other slides in about testosterone, which can be a tricky wicket with cancer. But I will tell you, if you want to learn more about even with prostate cancer, that's always been considered a contraindication for testosterone, but I will tell you today, in this day and age, most people do give testosterone to men after prostate cancer treatment. The majority of urologists do that. About 10 years ago, no one did it. And the reason is because of the work of Abe Morgentaler, who found that there is one study, one case study, that said testosterone is like fuel on the fire for prostate cancer. One from the 50s. And so now he has created a body of evidence that says that testosterone, you need to look at the science all the time, may actually be protective from prostate cancer. That's really revelational. And not only are we using it in patients who have had treatment and no longer have prostate cancer, but they're using it in active prostate cancer patients, and they're seeing that they're not having more prostate cancer, and sometimes they're having less. So watch the research, especially from Abe Morgentaler, who's up on the East Coast, and he's done some great research to show it can be safe and effective. So there's lots of different things to think about with it. We can do injections, we can do topical, we can do pellets, lots of ways that we treat people with testosterone. We talked about the oral agents again. I just wanted to put some information in here about the different treatments. We talked a little bit about the vacuum pump, which requires practice, patience, and teaching, definitely. So do the pills. I had a patient who said, I don't know how to take the pills because the bottom line is the pills, we have dinner and then we go dancing, but you say I take it on an empty stomach. So we sat down and figured out. You take it an hour before the meal. It lasts for 36 hours total. It's going to peak in about an hour and a half to 2 hours. That's after dinner. Now you're dancing. It's still going to be up there when you get home and want to have sex. These are the kinds of things you have to help them figure out to integrate it into love play. There's also injections, and you think, oh my God, who would stick a needle in their penis? Well, you'd be surprised. Millions of men were willing to stick a needle in their penis. And the reason is, first off, I did 1 of 3 studies that showed it doesn't hurt. In fact, 40% of the men in my study, and there were 60 men in my study, rated the pain 0 to 10, 0. They said, I felt it go in, it didn't hurt. It's a very fine, it's a very small needle. It's still not for everybody is the bottom line. The last story I tell you about one of my patients is going to be about injections, so I'm going to share that in just a minute. But it takes It takes work to get people up to speed on this. They have to learn how to do it. They have to show you they can safely do it without prompting at home. But it can be life-changing for some people to use these very strange therapies that help people regain penetrative and intercourse types of sex. I have a whole set of videos for men and women. It's free to anybody on the face of the earth. If you go to my website, drjeffalbaugh.com, you can get my book. You can download it completely free. Any patient can do it, and it's for prostate cancer patients, and it talks about reclaiming sex and intimacy after prostate cancer treatment. The Cancer Society, but different resources I wanted to give you. It's common. If you don't walk away with one other fact, know that your patients who have cancer and are having treatment, most of them have sexual dysfunction. And most of the time, they're too embarrassed to say. They feel upset about the fact that they're upset that even though they don't have cancer now, they are struggling with sexual dysfunction. So it really is on us to say, you know, many men and women who are undergoing cancer treatment have sexual dysfunction. Breast cancer, again, extremely common in breast cancer patients too, especially when they're on any kind of hormone manipulators. One woman said to me, "It's ridiculous. No one wants to help me treat this problem, but I'll tell you the truth. I would much rather be dead than keep living like this. It is very painful and is very uncomfortable." So these patients are really struggling, and they really need your help. Last story, so that you kind of, again, you wanted the patient perspective, and I'm happy to share that with you because every day this is what I do with patients. Man came to see me. He had had erectile dysfunction and he had prostate surgery. And so he was struggling. He was not getting erections. He tried different things. He tried the pills and failed. He tried the vacuum pump and it was okay, but he was not really happy with it. And he's like, it just doesn't work right and I don't feel comfortable with it. It's cumbersome. Even though it works at about 90%, it's far from perfect. Some people don't like it. So he wanted to do injections. His wife was with him, but he actually was diagnosed with erectile dysfunction 5 years before. So I said to him, "What happened?" Because this was way before your prostate surgery, which was only a year and a half, 2 years ago. And he said, well, his wife said, "Oh, that's when it all started." She said, "You know, what happened back then that changed everything for us sexually was my youngest son was killed in a car accident." You know, those are the kind of conversations that stop the room dead. You know, what could be worse than losing a child? And I said, "I am so sorry. I cannot imagine the impact that that has had in your life." She said, "That's not all. We have 2 sons, and 2 weeks later, because of it, our other son took his own life." They were devastated. They were hurt. They were upset, and they needed each other desperately. So I said, well, today we're going to try this. I had done all this work with them, teaching them how to do injections. They were all ready. They'd study all my handouts. They had watched my videos. They were in the office, and I showed them once, and then they did a beautiful job. She read it off. He followed the directions. They were a great team. They did a perfect injection. And then I said, "I'll come back in 5 minutes, and I'm going to see how it's going. Just move around a little. That's all I need you to do. Move around a little behind the curtain. You can bring your pants up and just move around because I don't want you to fall or anything." Pulled the curtain, walked out. Came back in, pulled the curtain back. He's there, pants around his ankle. He's got this erection. She's there. They're both crying. He picks me up and he hugs me like this. He said, "Oh my God, Dr. Albaugh." He's like, "Do you know what you did for me?" I'm like, "I'm pretty sure I know what happened to you here, you know?" And he said, "I haven't seen my penis hard in so long, I can't even tell you. This is a life-changing thing for us." She said, "You know what? It's not even the penetration of the intercourse, but the man I love is upset and absent from our marriage, and I want him back." This is the kinds of things that happen with these patients, and this is what they need. And they're not going to get it unless you, their trusted provider, say to them, "Are you having any issues? How can I help you?" And I hope, if nothing else, that that's what you'll do from the things that I've shared with you today. And I thank you for your time today. Thank you.
So I think we maybe have time for 1 or 2 questions.
I was like, oh my gosh, I don't know if I can ask a question about sex and intimacy.
It's an easy one. I'm Stephanie. I'm in Pittsburgh. I'm an REI fellow. I just had a question about how you would recommend that those of us find providers that are interested providing care to these patients when you have somebody who's looking for a resource and you're not sure which resource to use.
So how can you be helpful to these patients?
Well, how to find a provider who's willing to do this type of therapy and see patients who have complicated medical histories.
Excellent question. So first of all, if you need a therapist, a sex therapist or a relationship therapist, which is sometimes in particular what you need, you can go to www.aasect. It stands for the American Association of Sexuality Educators, Counselors, and Therapists.org, and you can find providers near you that are I'm a sexuality counselor or sexual therapist, and you can find them that way. In general, most of us are advanced practice nurses and PAs because it's very time intensive. I spend an hour with every single patient on their intake and sometimes an hour on some of their return visits. But usually urology office is one place that sometimes you can find resources and clinicians, and gynecology office sometimes. But I will tell you, when I started in this, neither of them did that much with it because they were all like, yeah, no. I was like, well, I started with women because they kept saying to me, well, now you're helping my husband, but I have problems. This was decades ago. But I went to the gynecologist. I said, what's going on? These patients are telling me that the gynecologists aren't able to help them. The gynecologist is like, no, we don't deal with that always. But that's in general, is the gynecologist's office, the urologist's office, and then the sex therapist. Sexual Medicine Society, smsna.org is another way to find sexual specialists in both urology and in gynecology. But it's a great question. But the biggest thing, the simplest, easiest thing is just ask the question. It's scary that someone has an ostomy now and no one, and trust me, a nurse friend of mine said the same thing. No one talked to her about sex and intimacy, and many of my patients who come in, no one has talked to them about sex and intimacy. Not a doctor, not a nurse, not anyone. So it can really, really be struggling for them. So I'm praying that you will do that.